Okay, so next speaker is Roberto Delfrate. He is an Italian venous hemodynamic expert and expert in venous hemodynamics. He specialized in general surgery, vascular surgery, and sclerotherapy. And he has a practitioner of CHIVA concept. And his title is CHIVA Strategy, Past, Present, and Future. 意大利的 Roberto Delfrate 医生呢，他是从事了非常多年的这个CHIVA手术，他可以说是全世界完成CHIVA手术最多的医生之一吧。他是普外科医生、血管外科医生，也非常擅长硬化肌治疗。那么他的题目是CHIVA策略从过去走向未来。
偏见、虚假信息、bias, false information, conflicts of interest, lack of ethics, aggressiveness of multinational corporations, intellectual laziness have been and are elements contrary to the scientific progress that CHIVA represents in venous pathology. Since the 16th century, clear medical research that there were forces in nature responsible for abnormal behavior in veins with clinical consequences. Several pioneers understood the therapeutic importance of vein ligation in the presence of particular clinical conditions. Trendelenburg and Perthes demonstrated in 1890 the relationship between lower limbs varicose veins, hydrostatic pressure, and pressure due to the valvular muscle pump. 98 years of pathophysiological darkness followed after Trendelenburg and Perthes. From 1905 to 1988, stripping, phlebectomy, and chemical ablations were the only treatment options available for chronic venous insufficiencies. The goal was not to find out why varicose veins occur, but only how to eliminate them. No interest was taken in pathophysiology. Recurrences were only considered a consequence of poor surgical radicality. In 1988, Claude Franceschi presented the new hemodynamic pathophysiology of venous insufficiencies and the CHIVA therapeutic strategy, a consequence of the reevaluation of venous insufficiency, thanks to his pioneering experience of continuous wave Doppler first and echocolor Doppler later. Claude was particularly heard in Spain by Samso and in Germany by Erika Mendoza and her husband. In Italy, too, several pioneers contributed to the spread of hemodynamic culture, becoming close students. Among them, I might mention Massimo Capelli, Stefano Ermini, Mauro Pinelli, Fausto Passariello, Paolo Zamboni, Antonio Di Gioia, and myself. I'm personally honored by the intense work done together with Claude from 2003 until the 2020 pandemic, first in Fiorenzuola d'Arda and then in Cremona. Particularly, the 17 years in Cremona allowed the spread of hemodynamic culture. If we are here today together with the SMILE medical group, it's thanks to the Cremona period, not without personal repercussions, as some of you know. I came to meet Claude after having independently realized the importance of hemodynamics. This introduction is necessary to tell everyone that observing reality with an open and critical mind leads us to knowledge. CHIVA is all the time being criticized for 4 different reasons: lack of scientific evidences, usefulness of preserved retrograde great saphenous vein for bypasses, poor response to cosmetic needs, and high number of recurrences, difficulty of the learning curve. Let's start with confirmation from the scientific literature. CHIVA is validated at the highest level if we use the PICO system score for guideline preparation, as you can see in this slide. CHIVA should therefore have a high degree of recommendation. The assertion that the CHIVA strategy is not validated by literature is a fake. CHIVA is validated by RCT studies, Cochrane reviews, and network meta-analysis. In addition, thanks to CHIVA experiences, we have improved knowledge of pathophysiology. For example, we know more about perforators and pelvic leaks. To further explore both topics, I invite you to read the two publications referenced here. Discussions about the usefulness of the great saphenous vein for bypasses are frankly surprising. There are many reports in literature on the usefulness of the great saphenous vein as a prosthesis for many uses in vascular surgery, particularly for coronary revascularization as well as for distal femoral bypasses, especially below the knee. The slide shows only a few works. I do not want to focus on this evidence well clear from the literature review, but to add other details, perhaps less known. Indeed, little is reported in literature on the histoarchitecture of the great saphenous vein, especially the post-CHIVA great saphenous vein. Great saphenous vein increase muscle component over time. Propulsive veins adapt to work by increasing the muscle component, as an athlete does with training. In the Chiaruggi-Bucciante textbook of anatomy, was reported the adaptive capacity of the propulsive veins to work by increasing the muscular component of the vein wall. The muscle component is different in a child with respect to an old man. Following Chiaruggi-Bucciante, the occurrence of great saphenous vein arterialization in response to mechanical work has also been subsequently reported in the literature. Nevertheless, even today, incomprehensibly, there is still a debate in the scientific community about the usefulness of the preserved great saphenous vein for vascular surgery uses. Personal analysis of great saphenous vein histoarchitecture on specimens obtained in special cases at least 1 year after saphenofemoral TSFL disconnection clearly showed a perfect structure of the venous wall, as you can see on the left, when a regular appearance of the vessel profile is shown at the B-mode evaluation, as you can see on the right. By comparing the histoarchitecture of the post-CHIVA great saphenous vein with a group of 10 normal great saphenous vein, adequate histoarchitecture was allowed to be certified. Indeed, in the post-CHIVA saphenous veins trained to pressure work, a greater muscular component was evident. Therefore, these are absolutely suitable veins when used for bypass. In this slide, I present the clinical case of a rescue bypass that I performed using great saphenous vein in a shunt type 3. The 5 mm diameter and the regular ultrasound appearance suggested adequate histoarchitecture of the venous wall. This was a useful great saphenous vein for bypass despite being retrograde. CHIVA poor response to cosmetic needs is a further fake. After every CHIVA treatment, it's necessary to wait for healing time where the shunt veins recover a better size. Thereafter, sclerotherapy is feasible if needed for cosmetic refinements. Regarding the difficulty of the learning curve, I can say that understanding and applying hemodynamics to venous pathophysiology and therapy requires study and perseverance. The modern angiologist must be autonomous in ultrasound investigation as well as in surgical therapy and sclerotherapy. For future, we need to look for know-how wherever it is. Surprisingly, we may find it in individual physician and not in university. The new generations of physicians will understand the value of venous hemodynamics, and change will occur according to the new knowledge of venous pathophysiology. But we can accelerate the change for the patients who need it by providing young students and physicians the information they need. To continue the educational activity carried out for about 17 years in Cremona, I accepted the invitation of my friend Di Gioia to create a phlebology academy. Other friends, including Roberto Delfrate, 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 Ro who are experts in CHIVA have joined, and the Academy was officially created this week. I believe that these aggravative experiences are the indispensable tool for spreading the hemodynamic culture. A partnership between us and you is necessary. Thank you for the invitation, and thank you for your attention. I hope we will go ahead together for science. Together is better. Thanks.
Okay, thank you. Thank you, dear Delfrate. Long time no see. And congratulations at the same time for your academy. And you give us excellent topic and show us the strong evidence about the advantages of CHIVA. Yes, we met too many, fake news about CHIVA, and the same in Europe and same in China. Yeah. And I think that's met because most surgeon or most doctor, they don't know, or they are very hard to have deep understanding of CHIVA. So that's what the means of our work. And it's also the meaning of this kind of conference. And we want to spread the CHIVA theory to more and more doctors. Okay. 我们那个 Delfrate 先生呢，他是克里莫纳中心的一名血管外科医生，他是有非常丰富的 CHIVA 经验。那我们中国的 CHIVA 之旅呢 ，CHIVA 开启的起点也可以说是在意大利克里莫纳。刚才呢，他跟我们分享了非常精彩的内容。那现在我想看看现场的观众们啊，因为他的手术技术是非常好的，临床实践经验是非常丰富的。大家有没有一些问题或者一些交流想和他沟通的？ OK， 那如果我们的现场观众没有的话，我们 Please Claude, do you have any comments or question?
Yes, I have just to show you something, if I can.
Claude 想跟我们分享一些东西。
I would like to show something, because I can't.
You've sent it to Sophie?
Yeah, yes. Not only l'animateur.
It's a video or some...
activate the share of the screen share. Could you activate it? I have just to show something.
请控台把那个共享屏幕权限给 Claude.
Yeah.
共享屏幕权限。
Yeah. Just to show something. Okay. Well, I am not it here. Just try to find it. You see it? This is not yet.
Not yet.
Okay. So, yes, that's a mess. Maybe.
We can see it now.
You can see it now.
Yes.
Okay. Okay. And here you have the book you can download. It's free. You can download it. You have 4 languages different and English. And you have to go to the site, which is angio.info. It's very angio.info, and you get everything, and a lot of documents. And you can get also my last book, and where everything is updated for all the venous pathophysiology, pathology for superficial and deep venous insufficiency, as well as venous malformations, with also the participation of Sophie, Victoria, and the Chinese group, who gave me some of the cases of the patients. It's okay? Did you see angio.info? Fine.
Yeah, we can see. Thank you. Thank you for your sharing. 那个 Claude 先生呢，非常的无私啊，他们这个 CHIVA 学者们都是非常愿意推动这个理论传播，所以这本书呢，它是可以免费下载的，我们可以去搜它的作者名，
它现在再版了，再版的这一版也是非常棒的，大家可以在互联网上免费下载啊。
Okay, thank you, Claude.
继续吗？
Fine.
So do you have any question for the last two speech? If no, I have a question for Dr. Delfrate. I'm sorry, for Claude. Because I see you use deep CHIVA to treat deep venous insufficiency. So what's the indication when we treat it? 我的问题是，治疗深静脉功能不全的时候，什么样的指征我们可以做这样的手术 ？Thank you.
You know, CHIVA is born from the understanding a model of venous pathophysiology based on hemodynamics. So CHIVA is just the implementation of this model to the superficial veins. But this model works also for the deep veins. And so what is the treatment for the deep veins? It's easy. You have to reduce the transplant pressure. You have to reduce the venous pressure. And why? So if there is an obstruction, you have to to open the obstruction with the stent, whatever. If it's an incompetence, you have to treat the incompetence, and most of the time you have, like in the superficial veins, you have shunts. There are shunts instead of being superficial, there are deep shunts. And you disconnect, as you have seen in the video, the shunts. In the video, there are two cases where the shunt was in the thigh between the superficial femoral vein and the deep femoral vein. And the second one was a double posterior tibial vein where one was incompetent and the other one was competent. So you have just to disconnect the incompetent, which is, and with very good result. And it's easy, very easy for who knows, for who studies. That's why once more, please, if you, for all the attendants, if they want to understand something and see something properly, it's not knowing is not sufficient. You have to understand, and to understand, you have to study, and to study, we have books and mentors for that. And the last book I wrote, and you can download from my site, angiopoint.info, is you read it. It takes time, okay, but the more you take time to study, the less time you need to do and understand your patients.
Okay,
Did I
thank
understand?
you. Thank you. Okay, Roberto, please.
Yes, regarding, can you hear me?
Yeah,
Can you, okay.
we can hear you.
Regarding the deep CHIVA, it's absolutely mandatory to have the possibility of an echo-duplex checks during the operation. And this is why you can avoid mistake if you are on tibial veins and only one is a retrograde vein. And so you have to preserve the good and to eliminate the wrong. And for the femoral vein disconnection, before cutting the vein, it's better to have a check during the operation, squeezing the calf and observing when you close with the vessel loop, with the tourniquet, when you close the superficial femoral vein, if squeezing the calf, there is a systolic wave in the femoral vein. Well, and doing this, you must consider, if you want to do not only once, but 2 or 3 times the squeezing maneuver in order to be sure that there is the possibility of drainage without the superficial femoral vein. You have to consider the refilling time you need because the patient is horizontally on the operatory table. And so you have to wait a correct refilling time. If you don't respect the refilling time, you squeeze the calf up where you cannot see anything in the femoral vein. Of course, this is not an easy surgery. This is a surgery for a surgeon who is an expert in general vascular surgeon. For example, regarding the dissection of the tibial veins, both the tibial veins are really close to the artery, and it's not so easy to dissect the vein from the arteries. And there are a lot of veins going from one tibial vein to the other. And so you need to isolate this vein that are vein that join the two tibial vein. And regarding the indication is a venous ulcer that is not responsible for other treatment. In the case of that Claude shows of the femoral vein dissection, the first case shows of the CHIVA. I did before a superficial CHIVA, but it was not sufficient for the healing of the ulcer. So with Claude, we started this wound, and we decided to go to do the deep disconnection. But of course, this is not for beginners, but for a skilled surgeon and skilled hemodynamist.
Thank you for your comment.
I still have a small question for Delfrate. Using titanium clips to occlude the SFJ, I want to know, would the patient experience local discomfort during the post-operation time? Thank you.
Sorry, can you repeat? Because the audio is very low. It's difficult for me to understand.
Okay, I mean...
You asked something about the titanium clip.
Yeah. I mean, you use the titanium clips to close the SFG. And I want to know whether the patient have some local discomfort feelings after the operation.
No, nothing. Nothing.
None.
Absolutely.
No one. Okay.
No,
Thank you.
no.
Thank you.
It's incredible, but it's true.
Okay. Thank you. 刚才呢，两位教授也都谈到了，就是说我们只有学习了血流动力学的一些理论，我们才能分清楚生理和病理性的区别。那么对于病理性的，又包括患者有症状的，那么和患者充分沟通交流之后，你可以选择去治疗病理性的问题。那刚才 Delfrate 医生呢也强调了说，在术中啊，我们也要进行非常谨慎的识别，以及再确认。因为手术呢，我们讲 theory 好像很成立、很简单、很通畅，但是你在做 practice 的时候呢，你还是要有一些非常细节的地方要注意，因为这毕竟是深静脉系统。所以这是两位教授给我们的一些 comments。Okay, thank you.